So as Rich said, I'm going to be giving a little 5-minute talk here, something that's near and dear to my heart. So a little about education here with bedside versus hallway rounding, and we can get started. So a little background on this. So bedside teaching has declined in medical curriculum over the years and actually is no longer the most common rounding style in most hospitals. This is believed due to increased patient turnover and high quality diagnostic procedures, but is also despite evidence of patient satisfaction and improved nursing communication with bedside rounding. There's really been a lack of data to guide us in rounding practices, specifically in neurology, and optimal rounding methods remain unclear. So there was actually a new study or trial done with Dr. Solomon at Brighams, and it was published here in Neurology in 2021. And so this was a randomized study of bedside versus hallway rounding. So the objective was to compare bedside rounding with hallway rounding on an academic neurology inpatient service, and we're assessing efficiency, trainee education, and satisfaction among patients and staff. It was designed as a single center prospective randomized trial only on new admissions in over 1 week blocks. Now the bedside team presented patients at the bedside, whereas the hallway team presented patients outside of the patient's room. So the primary outcome was kind of broken down here into the mean rounding time and the actual proportion spent at bedside. This was recorded by time motion analysis with a research assistant following them around on rounds. And interesting enough, the mean rounding time per patient on the bedside group, which was 38 patients total, and then the hallway group, which was 41 patients total, was 23 minutes and 23.2 minutes respectively. So basically the same there. And then as far as the bedside group spent on average about 57% of their time rounding in the room as compared to the hallway, which is around 40% of that. When they looked at secondary outcomes, this was more satisfaction among the patient, staff, and faculty. This was evaluated through a 5-point Likert scale survey. And so patients viewed bedside and hallway roundings really similar, though when asked, patients who experienced the bedside roundings preferred that. Nursing, they perceived improved perception of their participation with rounds, as well as felt more heard during rounding process. Now, the residents perceived the hallway rounding to be more efficient than bedside rounds and associated with a superior educational experience, along with a more effective data review. On the other hand, attendings perceived the bedside rounds to be more efficient and with better teaching of the history and physical exam techniques, but they did feel that the data review was better served in the hallway group. So just a little discussion here. Bedside rounding was perceived less favorable by most of the residents, but actually was as efficient as hallway rounding per the time motion analysis there. Now, this is maybe a paradoxical perception. Perhaps it's due to some anxiety about being in front of patients and presenting data review challenging, and also the pressures of these time-sensitive tasks that we ask of our residents to complete, which requires a computer. Although bedside rounding limited the use of technology for data review, it prompted nursing participation and resulted in more time spent with the patient. This was a limited sample size here in this trial with a low power, and actually was cut short due to COVID and only a single center. So there are plenty of things that can be improved about this trial, as well as not a whole lot of other outcomes measured. Just my 2 cents and last slide here. So as we probably have all experienced as providers, spending time with our patients at the bedside, we found, maybe that one bit of history that really changed the diagnosis or way we approach that patient. So keeping that in mind. Also, I believe probably bedside rounding, especially if you're having nursing staff with you, may reduce the number of paging burden that our residents experience. But with all that said, I encourage everybody to kind of step outside their comfort zone and try different rounding approaches to see what works best for your team as well as your patients. And we kind of have to remember that each individual patient is individualized. So patients with delirium comfort care, for instance, might not be the best for a bedside approach. And that is it.
Thank you, Jordan. Very wise words indeed. So now I'm going to turn it over to Dr. Chris Eckstein to introduce today's Grand Round speaker.
Thanks, Rich. So it's my pleasure this morning to introduce the next speaker in our Chief Resident series. So I think pretty much everyone will probably know Elijah Lackey. So he is currently one of our chiefs and has worked very closely with us in the neuroimmunology group. He came to us by way of Ross Medical School, and prior to that was at UNC, actually, just across town. He's going to be staying with us next year for a neuroimmunology fellowship and plans to do some additional research, hopefully with Simon Gregory. Today he's going to be talking about sarcoidosis and some of the complications we've seen with that. So he's gone through a lot of charts here, and hopefully we'll have some good information for us.
Thanks, Dr. Eckstein. Let me see if I can share my screen here.
Looking good.
Okay, is it in presentation mode?
Yep.
Okay. All right. So I've broken this talk into two parts. I've got a background in neurosarcoidosis, about neurosarcoidosis, and then more about the patients here at Duke and then the charts I reviewed, like Dr. Eckstein said. So this is kind of the outline. We're going to go over the history briefly of neurosarcoid, some of the epidemiology, and then pathophysiology, diagnosis, and treatment options. So this was originally described back in 1877, at least sarcoidosis was, when a violaceous skin lesion was biopsied, and it showed a non-caseating granuloma similar to sarcoma under the microscope. And then it was found that sarcoidosis can affect really any system, but most often it's pulmonary, about 90% of cases. Slight female predominance, median age around 40 years, but most commonly seen 20 to 50-year-olds. Higher incidence, and this is kind of debated amongst African Americans, more so than Caucasians. There's been some prior studies maybe showing that Northern Europeans perhaps have a higher risk for sarcoidosis, but that's somewhat debated in the literature. There is known workplace exposures for sarcoid in general, but those are not yet identified for each of the different organ systems. There is an increased risk. There was an identified increased risk in people who were exposed to dust from the World Trade Center collapse. That was part of the ACCESS study. And around 10% of cases of sarcoid present with neurologic symptoms. So here's that kind of classic non-caseating granuloma that I mentioned. You can see some lymphocytes around the outside. You can have inclusion bodies, and you can actually have different types of inclusion bodies. I went back to my old med school pathology textbook, and it seems that asteroid bodies are probably the most commonly seen inclusion bodies, but it can be several different other ones. I put a little picture of a caseating granuloma here to show you what tuberculosis looks like, and that's not sarcoid. And then some of the theories behind how sarcoid happens, the pathophysiology. Probably the top three prevailing theories are that there's some genetic predisposition and then an environmental trigger, but nobody really knows for sure. There's also debate, could there be ongoing bacterial infection from an atypical bacterium? Could be related to like an acute phase reactant like serum amyloid. And there is evidence for serum amyloid aggregation in these non-caseating granulomas. There have been some associated genetic mutations, mainly single nucleotide polymorphisms that predispose people toward having sarcoid. I made this chart to kind of help distinguish, what some of these are. Unfortunately, we think that this probably, and I'll show you in the next slide, probably only accounts for about a third of our cases. We really don't know much about the genetics behind sarcoidosis, and we really only have one genetic mutation that ZNF 592 that can account for some of the heritable risk for neurosarcoidosis. That's the only one that we know of for neurosarcoid in particular, at least that I found in literature review. I included some of the other ones. I think from med school, people probably might have heard of that HLA-DRB 13031 for Lofgren syndrome. And then there have been some studies showing that insecticide exposure is associated with these HLA haplotypes. I found this kind of interesting paper about environmental exposures, but there was nothing specific for neurosarcoidosis. So you can see neurologic involvement. There was no specific environmental risk, at least in this study that was seen. And I didn't find any other papers that seemed to indicate there was a particular environmental risk for neurosarcoidosis. Clinical presentations of neurosarcoidosis are quite variable. It's previously been thought that single cranial nerve involvement was the most common presentation, either optic nerve or facial nerve. That's been somewhat debated recently. A very recent paper came out saying that maybe it's really just headaches and that we're catching it earlier with imaging. Multiple cranial nerve neuropathies is what we were taught in medical school, but that's probably not very common actually. And then it can cause pretty much anything else in the nervous system. And the small fiber neuropathy one perhaps is also debated. Is that related to amyloid deposition from acute phase reactant? Is it actually part of the sarcoid? Is it part of the sarcoid pathology of invasion of nerves? So I think it's good to know that it's just a highly variable presentation that can occur. Some things that might clue you into neurosarcoidosis, ocular involvement, and that's a pretty wide range there of 25 to 80% of cases neurosarcoid, uveitis, lacrimal gland involvement, and then some different skin findings, a variety of skin findings. The diagnosis, this was from a paper in 2018. You really need tissue to make the definite diagnosis. And so you need that central nervous system biopsy to give a definite diagnosis. The probable diagnosis is obviously made on biopsy of a systemic, usually lymph node, showing non-caseating granulomas. The typical workup for these patients, they're going to present with, like I said, maybe headache, possibly a cranial nerve neuropathy, but it can be a lot of other things. We're usually going to get that MRI brain that's contrasted. Most often shows leptomeningeal enhancement. Oftentimes vascular, but doesn't have to be. A lumbar puncture may show lymphocytic pleocytosis, and then you're going to go looking for other causes for this. Obviously, you're going to consider a differential diagnosis that's going to be pretty broad, whether it's fungal infection or an atypical mycobacterium. And then you also want to consider, where are you going to get a biopsy from if you're considering sarcoidosis? And most of the time you want to go to the lungs and look for enlarged lymph nodes, starting with a chest x-ray, followed by a CT scan or PET, and then biopsy for that definite diagnosis. This was, for people who like algorithms, I wanted to include this one as a pretty extensive breakdown of how to consider a differential diagnosis of neurosarcoidosis. For the purposes of my talk, I wanted to mention that I'm going to focus on central nervous system disease. So certainly neurosarcoidosis you might consider as, causative for small fiber neuropathy. I didn't look at patients who specifically had small fiber and sarcoidosis. So for the purposes of the rest of this talk, I will be focused on central nervous system disease. I think, need to say a few things about ACE here. So when people check ACE, usually they get a little bit criticized, but, I think that there's some, my kind of takeaway is that checking an ACE might not be terribly sensitive, but perhaps if it's dramatically elevated, it can be helpful. You can see this recent review from this year shows that serum ACE may be elevated in 24 to 76% of patients. There was one paper, there was a case series where none of the patients had an elevated ACE, which is kind of interesting. So I think if it's negative, it's not helpful, but if it's positive, it might clue you in to the diagnosis. And then I should briefly mention here too, in terms of specific imaging findings, the trident sign was described a few years back in 2016, with a dorsal leptomeningeal enhancement that looks somewhat like a trident with involvement of the central canal. And treatment options. So usually acute treatment is going to involve steroids at high doses. So usually pulse dose steroids, Cymedrol, a gram daily for 3 to 5 days, followed by oral prednisone, usually for a very slow taper, a very gradual taper over months. The steroid-sparing agents that have historically been used, I've got listed there, along with my interpretation of the literature about how effective they are. With some of the more recent literature, some indicating that the biologics, particularly Infliximab, might be the most effective for central nervous system neurosarcoidosis. And I've got another slide on that here on the next one. So anti-TNF alpha antibody treatments. And that's what this slide is about here. So you can see people have been thinking about that for a long time. People have been considering Infliximab as a treatment for neurosarcoidosis since the early 2000s, but there was really a paper in 2017 that showed that it was a multi-center study. It was retrospective, but it had over 60 patients, and all of them did quite well on Remicade. There is some evidence for Humira, excuse me, maybe quite a bit less evidence, I would say, than for the Infliximab. But I think there's a lot of interest in using the Humira, the adalimumab, rather than Infliximab going forward. So then I'm getting to the kind of the interesting part of the talk here. I'm going to go ahead and talk about the research we've done looking at our cohort. So I've got a lot more information to tell you guys about here. This is the breakdown of the second part. We're going to talk about what the Duke cohort looks like, along with the diagnosis of these patients, their clinical features or presentations, and the complications of their treatment and the disease, smoking and its risk for getting neurosarcoidosis, and then some of the prescribing practices that have been seen here at Duke. So this is part of a couple of IRB exempted retrospective chart reviews. Looking over the past 10 years at patients with a diagnosis of neurosarcoid, I used Deduce to identify these patients who were followed by neurology providers here at Duke. So identified over 100 patients. And in particular, these IRB exemptions were written looking at refractory sarcoidosis, complications of the disease, and adverse effects of treatment of the disease. Our cohort at this time, and I'm still working on it, as a lot of patients, it's taken a long time to look at all these charts. Over 90 patients, and 92 looked at so far, with a median age of 44, but ranging in age from 20 to 74. And there may be younger patients seen here at Duke, but we did limit our study to looking at over age 18. With a slight female predominance, which fits with the literature, slight African-American predominance also, which also fits with literature. I want to point out that, Tom Brady is also 44, which is, again, the median age of our cohort. So in terms of the diagnosis and treatment of our patients here at Duke, the average delay in diagnosis was about 6.5 months, which pretty well fits with literature in terms of delay to diagnosis. It's hard to make this diagnosis in patients, because a lot of times you need the biopsy. The serum or CSF ACE was checked in 37 patients and elevated in only 14 of those. Most patients received pulse dose steroids during their acute admission to the hospital, and then were started generally on 60 milligrams per day. So a handful of patients, 8 patients, were not started on steroids and were only started on a steroid-sparing agent. I tried to look at how the tapers were done over what duration and also what dosage, but that was very hard information to get from the charts. And I'm still working on that. A lot of patients discontinue their steroids because of the adverse effects. A lot of times the exact taper is not written out in the chart very clearly. Perhaps it's conveyed verbally to the patient, but not necessarily described in the note from the encounter. So most commonly prescribed initial steroid-sparing agent was Celsep. mycophenolate, followed by infliximab. And then we also saw patients being prescribed methotrexate. We saw azathioprine, cyclosporin, a variety of agents. 29 patients did have recurrence of their disease or perhaps persistence. It was kind of hard to tell. 15 out of 29 of those had already been either taken off their prednisone or were just on prednisone without a steroid-sparing agent. 5 out of 29 were on infliximab, interestingly. And 3 of those were on an additional steroid-sparing agent. So I do wonder whether there was sort of a severity bias there, with more severe cases of the disease being treated with more than one agent and having persistence of the disease. The clinical presentation of these patients, our clinical presentations, excuse me, we saw here at Duke fit pretty well with literature also, in that most of them presented with headache. That was the most common symptom. I shouldn't say most. The most common symptom was headache, then blurry vision. And you can see the rest of the presentations were smaller in percentage than headache, but just a highly variable presentation. And I made a little word cloud here so you can visualize that a little bit better. I'm not sure why right came up so big. It seems like right-sided symptoms were more common amongst our cohort. I don't know. I don't think there's any meaning to that, but you can see that headaches came up as the largest probably. And then looking at where people got biopsied, most commonly it was pulmonary, and these were positive biopsy results, most commonly pulmonary, and then systemic lymph nodes. Only a few of those. We had 17 definite central nervous system neurosarcoid diagnoses made, which is a pretty large number. When you're looking at like the Geflin cohort from the 2017 paper for infliximab, is about the same number of patients, and that was over 6 different centers. So some of the examples of what we saw for central nervous system neurosarcoidosis, these were in patients who received biopsies, and those biopsies were positive. So we can see that there's a left pontine enhancing lesion for this patient. Over here, significant dural disease, along with some leptomeningeal disease. Basilar leptomeningeal enhancement, and then you've got involvement of the spinal cord here, both leptomeningeal and within the cord itself. So again, a wide variety of imaging findings, which I did break down the number of patients who had leptomeningeal disease versus parenchymal and myelitis. We had the majority of our patients with leptomeningeal disease, followed by parenchymal disease. Myelitis was only in a few patients. So these are, again, the definite neurosarcoid cases. And to just kind of give you the brief imaging presentation of what that looked like, you can see that, we saw this wide variety again of presentations on imaging. It can be pretty much anything in terms of how the disease presented. And that's the remainder of that cohort of definite neurosarcoidosis by biopsy. Interestingly, one of those was a patient with ischemic strokes. So looking at CSF, I think not surprisingly, most common finding in CSF is fairly nonspecific in that it was a lymphocytic pleocytosis. In almost every patient in whom CSF was obtained, they had lymphocytic pleocytosis with a cell count between 18 and 24. That was the median cell count, with some significant outliers. One patient with a cell count of 523. And then elevated protein was less common, and only 68% of those patients in whom it was checked. I was considering one perspective. Clinically, we're often wondering whether parenchymal disease, whether it's useful to check CSF. And it looks like if it's not leptomeningeal, dural, or myelitis, essentially, and it's parenchymal disease, you could expect maybe a lower CSF cell count. But again, that's just a very small number of patients that we have data for. one of the things we looked at, we were curious about was how our treatments are affecting our patients, and in particular weight gain, because of the duration of steroids for these patients. Some of these patients are on steroids for years, and they are often treated at high doses, sometimes repeatedly for years. And we saw pretty dramatic weight gain. And I think there's different ways to look at this data. I think that perhaps I'll analyze it differently than looking at median BMI changes in the future, perhaps looking at actual like absolute change of weight. But I think this is fairly illustrative of our patient cohort. Looking at the first 6 months, you can see that chart up on the right top side of the screen there. You can see that they essentially went from being overweight to obese with a BMI around 28 going to about 33 over just 6 months. If you look at the data going further out, when patients come off of steroids, their BMI seems to come down. So it appears, that this is probably steroid related. For some of these patients, there was very dramatic weight gain. You can see the patient down there in the right lower corner of the screen went from a BMI of 27 to 37 over the course of about 1 year, which is pretty terrible. And from sort of anecdotal experience in the clinic, I've had some pretty upset patients who have gained a lot of weight on the steroid regimens that we use for treating this disease. Another significant adverse effect that we see, it's not too common, only 3 patients, but it's pretty terrible, obviously, is avascular necrosis of the femoral head. We had 3 patients out of these 94 patients that we looked at so far who had avascular necrosis. 2 of those had bilateral avascular necrosis. Pretty terrible and debilitating. Another disease complex, this is kind of shifting gears, I think, from the adverse effects of treatment to disease complications, is obstructive hydrocephalus. We had 6 patients who had obstructive hydrocephalus requiring intervention. 3 of those received a third ventriculostomy and 3 received a VP shunt for relief of that obstructive hydrocephalus. This is one of our patients down here in the right lower corner. I believe that's one of Dr. Eckstein's patients who received a third ventriculostomy. Something that came up looking at the data was smoking as a risk factor for development of central nervous system neurosarcoidosis. There is conflicting literature on this. If you look back over the years, kind of early 2000s, the case control studies seem to indicate that there was actually a reduced risk of sarcoid in patients who were smokers. But more recent studies, when you look at gene interactions and these gene environment studies, show that with certain genetic mutations, there is an increased risk for patients who have that genetic mutation and smoking. So it's a little bit complex because, and it's also not specific to neurosarcoidosis. That paper broke down patients who had Lofgren syndrome versus non-Lofgren syndrome. But there is no paper looking at smoking and central nervous system neurosarcoidosis, which I think is an area of further study to look into. Interestingly, we had 13 patients who had more than 2 relapses. 6 of those patients were either active or prior smokers, and 2 of those patients were marijuana smokers on a regular basis too. This is a little bit more about that smoking and CNS sarcoid. These are some of the genetic mutations that seem to increase risk for non-Lofgren syndrome sarcoidosis. But again, no genetic studies have been done looking specifically at genetic risk, neurosarcoidosis, and smoking. So one of the areas we're very interested in, and that has been hard to interpret the data, it has been refractory neurosarcoid. So we looked at patients who had, earlier, like 1 relapse, 2 and 3 relapses. The problem with looking at this data is that many of these patients were treated differently. So I tried to make a timeline to show you guys like how they were treated, but it got very complex very fast because of the different treatment regimens, the steroid pulses, the steroid tapers, and also how you define the relapse versus persistent disease is very difficult. Some patients would have clinical symptomatic relapse without inflammation seen on MRI, and that makes it difficult to sort of define when this occurs. One of the findings from looking at this data, though, that is hard to say without kind of further investigation whether it's meaningful, is that it seemed like patients who had 3 or more relapses, those who had very either persistent disease or very refractory disease, had some sort of parenchymal involvement. All of those patients had some sort of parenchymal involvement except for one who, oh, actually, for that one, all of them did. It was when they had 2 relapses. There was one that was leptomeningeal predominantly. And then one of my most recent things I've been looking at, this is a different cohort, so this is slightly different data, just using slicer dicer to look at patients who were diagnosed with neurosarcoidosis here at Duke. This is not the sort of refined data looking at patients who have been seen in the neurology clinic. This is more of the overall, all the patients with that diagnosis, that ICD code of neurosarcoidosis. So again, slightly different data looking at what we're actually doing here at Duke. And we're seeing this increase in biologic prescribing, particularly driven by Infliximab, with a slight decline in use of CellCept, and the use of the mycophenolate. So you can see that here in this sort of kind of dark purple is the Infliximab, and the green is the CellCept. That top line is methotrexate. I have not yet used slicer dicer to look at how many of those were on both methotrexate and Infliximab, but I imagine a good number of them are on both medications. We had one patient who was briefly on tocilizumab. There is some evidence for that. You can see a slight little bump right here back in 2015, but no one currently on tocilizumab, at least that was found by using the slicer dicer data. And then Humira increasing prescribing seems to have slightly increased, but we've also got an increased number of patients here at Duke. You can see that the number of patients has dramatically increased over this past like 8 years. So this is all preliminary data. You know, all of these things that we've looked at so far are very preliminary and bring up a lot of questions about the disease and how to treat it and how to avoid some of these adverse outcomes. So I've got a list of some of my thoughts here, and there's actually more than what are listed. But how do you make that diagnosis? How do you follow these patients? How do you decide, you know, when to change treatments? And we don't really have a lot of data for that. A lot of people have tried to find biomarkers over the years, and they by themselves have not really been sensitive or specific enough to guide clinical decision making. I'm interested in proteomics, and I think that's where Drs. Gregory and I are going to go with looking at progressive MS. And I do wonder whether that could be applied here to sarcoid. I think that because it's such a rare disease, that could be very difficult to do, but perhaps is a possibility for the future. One of the questions I had was, you know, when patients come into the hospital and there seems to be a clinical relapse without MRI findings, is doing an LP useful? Is that lymphocytic pleocytosis persistent? Does it go away with treatment? I don't think we know that yet. It's not in the literature, and I haven't looked into that in our data yet either. The smoking risk and central nervous system neurosarcoid, we don't have a lot of information for that either. I think that gene environment case control study probably would be the best way to go. That might be a fairly expensive study to do, and it'd be difficult, obviously, because of the small number of patients that are here with neurosarcoidosis. The ideal treatment regimen, not really like hashed out in the literature, but Infliximab seems to be the way to go in terms of steroid sparing agents. But perhaps adalimumab, being similar in mechanism, may work just as well or better. We don't really know that. And then how long do you treat with steroids? We don't really know that either. Can we do better treatment in the future? Is there a way to guide like personalized medicine with genetics or biomarkers? I know that there's a sarcoid group here. I think some of the members of that group are on the Zoom call right now. But is there a way that we can join with other centers to get more information about particularly refractory disease? and how to treat that, whether it's refractory, persistent, however you want to view that type of disease. And then serum amyloid A, I'm kind of curious about. There's for familiar Mediterranean fever, they use colchicine to treat it, and they've tried to come out with some clearing agents to remove serum amyloid, which have actually not made it through clinical trials. But could there be a drug in the future that helps clear that, and does clearing of the amyloid reduce inflammation and perhaps change disease course? I don't think we actually know that yet either. All right, and then people who helped with this project, Dr. Eckstein, Dr. Shah, and then my fellow residents, Kristen and Dan Elvis, along with our medical student over in Neurology, Nilla. And then I probably have a lot of time here left for questions. I'm sure there's going to be some questions about this, but if anybody wants to ask any, you're welcome to do so.
Thank you, Elijah. So anyone who has questions, just either raise your hand or put your question in the chat and we'll call on you while people are getting that together. Elijah, for people who haven't used Slicer or Dicer, do you have comments on using it? Its strengths, its ease, its weaknesses?
It was easy to use. I kind of taught myself how to do it. It was, it took me a little bit of time to kind of figure out how to do the slices, and a little bit of frustration initially, but turned out okay, I think. And it has some pretty nice graphs for, looking at it visually, looking at data visually. I think it's a good pilot way to look at data clinically, and then perhaps use Deduce to get more deep into the charts and kind of refine your cohort.
Slicer Dicer actually has a meeting every Thursday at around 10 o'clock, and they'll walk you through your project for free.
Wow.
Yeah.
Okay.
Okay.
I'll just chime in on that too, just to say that Slicer Dicer is great for patient-centric data. So for outpatient studies like you're doing, Elijah, it slices up the data by patient. But if you're an inpatient doc and you're doing QA stuff, it's not very helpful because those are encounter-based questions that you tend to ask on the inpatient side. So for outpatient docs, Slicer Dicer is great, and I would highly recommend those classes and those meetings. But for inpatient folks, you're probably going to want to use Deduce.
All right, Jordan, you had a question?
Yeah. Hey, Elijah, great presentation. I was just wondering, I know we all don't love ACE serum levels, but you did discuss it and showed that perhaps if it's elevated, then that means that that might be able to help us with diagnosis approach and things. I was wondering, in those patients that possibly are having a clinical flare without any type of MRI evidence, have you looked at their serum ACE levels, and could that be used as a marker perhaps to help you in determining if this is a true flare and needing to be treated versus not, and if not, if that might be something you're considering in your future investigations?
So I have not looked at that, but I believe other people have. So, in terms of the biomarkers that other people have looked at in the literature, ACE doesn't seem to be, sensitive enough to use consistently for flares. I think, also it seems like ACE is checked so rarely at our center that that'd be difficult to look into. So it certainly is part of that consideration, but I do wonder if you could combine these biomarkers, perhaps, as part of that kind of a proteomic profile, and do a sort of a multivariate analysis and get a signal that might tell you whether they're having a flare. I don't know. So that could be something interesting for the future.
Thanks.
All right, Carolyn Pizzoli.
Thanks, Elijah. That was a great talk. Thank you so much. I wanted to know if you could expand any on the experience in your cohort of primary prevention of antibodies to Inflix or other biologics, and any monitoring that you would recommend, and if that's something you can fight through or always is going to have to require more prophylaxis or other methods to address.
I think that is an area of interest. I don't have the data for that, yet, in terms of like how many of our patients go on to develop antibodies against infliximab in particular. But that is an area to look into, and our rheumatology colleagues might know better than I do about like starting methotrexate early. I don't know the data for that in terms of prevention of antibody formation. It makes sense to me, like in terms of like, if I was going to give an ideal treatment, I'd probably say, start methotrexate along with infliximab as your first line steroid sparing agents, because it seems like infliximab is the most effective, and the methotrexate might prevent antibody formation against it to try to get that patient off of steroids.
Thank you. And that's, what Dr. Van Mater does is she puts them on the prophylactic low-dose methotrexate, and when we still have some struggles, sometimes she'll increase it to therapeutic doses, and we can get away with those two things together. But I didn't know if that was kind of a protocol people are doing in general.
I don't think so. It's not. Just looking at our patients, I can say that it's not a protocol. It's not something that's done consistently, but maybe it should be. I think that is something to have a discussion about amongst people who treat patients with neurosarcoid. I think it would make sense to me to go ahead and start methotrexate along with the infliximab.
And I'll just add to that on our more recent folks that probably came after this cohort, that is kind of what my practice is in clinic as well. If I'm starting infliximab, generally I will throw methotrexate in there. And admittedly, I'm often a little more liberal with the dose probably than what I would be normally, because I've seen a high rate of resistance.
Jim Burke.
Yeah, very nice talk. So how many of the people were initially diagnosed with sarcoid who then went on to get neurosarcoid? And are you missing a significant percentage of people, like looking at the sarcoid clinic to see how many people might have subtle neurologic symptoms that have just not been coded correctly as neurosarcoid?
And Elijah, before you answer, I just want to say, Jim, 2 years into the pandemic, you think the dog's mouth would start moving when you asked your question? Go ahead, Elijah.
So I think that's part of, sort of the sampling bias of this study, is that we selected for patients who were diagnosed with neurosarcoid. So all of these patients, had neurosarcoidosis, central nervous system neurosarcoid, and we took those patients. We didn't look at patients who had something else, and so there is bias to this study. We didn't look at patients who were later like undiagnosed with neurosarcoid. So I think that is something to consider here. I don't know if that's what you were asking about. And this, our data doesn't really look at like differential diagnosis so much. How many patients were considered maybe to have neurosarcoid and then later diagnosed with MS. We didn't really look at that.
Dorlin?
Hey, Elijah, really nice talk. You mentioned in the epidemiology review about the higher case numbers in African-American patients. And obviously here, that's a cluster that we look at closely. But at international conferences, there's lots of papers coming out of Ireland about the extremely high incidence rates there. And I'm just curious if you had come across any papers or knowledge about why that might be, and if there's anything in common we can sort of see in terms of risk factors for it.
I honestly don't know. I think, looking back over the years, even some of the older data seems to indicate that Northern Europeans maybe have a higher risk. It's kind of hard to say how many cases are we missing and that kind of thing. I don't know. I don't know enough about that, Dr. Kimbrough, to kind of speak intelligently to it. You may have seen more of those presentations, honestly, than I have in terms of epidemiology. I had put on this slide more about where there's been higher incidence, and then actually remove some of that information because I didn't want to get too deep into whether that was real or not. I just don't know.
Thanks. Elijah, when I was your age, we were doing blind muscle biopsies to look for sarcoid. Is that a thing still?
So perhaps in like peripheral sarcoid, so if you have like peripheral nervous system involvement, but in terms of central nervous system involvement, I don't think that's really a thing so much anymore. And the information that we looked at, the patients we looked at really only had central nervous system involvement. The study could be broadened, obviously, to look at patients with peripheral nervous system involvement. There's some evidence perhaps that risk for peripheral nervous system involvement might be increasing Caucasians, but that's also debatable. That information came out of Utah. It's kind of hard to say.
If you don't mind, when you say peripheral nervous system involvement, what kind of things we're talking about?
Primarily neuropathies. That's my understanding, but again, can cause about anything.
Okay. So last year we had one of the resident grand rounds was about syphilis, and that was the message then, that syphilis can cause everything. So amongst the can cause everything is syphilis and sarcoid.
Right, I think so.
Great.
And I didn't get into all of the like details about presentation of our patients. Some of these patients presented with seizures. I think I mentioned there was one patient who presented with psychosis. So it can be highly variable, somewhat like syphilis maybe, but maybe not quite the same.
All right, great. Well, that was certainly a great discussion. All right, thank you very much, Elijah, and everyone else, be safe and careful out there. Have a great day.